impact of obsessive compulsive disorder in sex life. In India, cohort prevalence of OCD, obsessive compulsive disorder, is around 0.7 to 0.8%. Means around 1 crore people in India are suffering from OCD, obsessive compulsive disorder. And there is huge impact of OCD in sex life. And these patients straightway go to general physicians, maybe gynecologists, maybe dermatologists for their treating their sex problem. So I'll for next 10 minutes or so I'll speak on this topic. So normal sex health is a dynamic and harmonious state involving both erotic and reproductive experiences. And sexuality is experienced in thoughts, fantasies, images, and roles and relationship issues. OCD has huge impact in sex life for both men and women, and get likely not to get married, and there is relationship issues, sexual dysfunction, infertility, and sense of insecurity. Okay. Sexual difficulties in OCD are complicated by lower rates of marriage and relationship, and psychosexual issues are important aspects of human life, and sexual health determines the overall quality of human life. Despite that, sexuality is not given due attention or due importance in the research with respect to OCD. So, regarding the presentation of impact on OCD, that is sexual dysfunction, huge sexual dysfunction that leads to difficulty to get married, relationship issues that leads to infertility, and ultimately sexual insecurity everywhere. So sexual dysfunctions and dissatisfaction in OCD can range from 54 to 73% in one research. In female patients, around 22% had sexual arousal difficulties, 9% had anorgasmia, and in males, around 25% had reduced sexual arousal, 12% had early ejaculation, and in both male and female, 39% had sexual dissatisfaction. In a research with female patients with OCD but not treated, and healthy subjects as controls, it is shown that there is reduced and absent sexual desire, there is disgust for sex, decreased pleasure for sex, difficulty to get orgasm, or if it is getting, there is unsatisfactory orgasm, and there is absence of pleasure. And there is no much difference for different severities of the disorder or different subtypes of obsessions, and it is not found to be restricted to the patients with contamination related obsessions. Some authors have reported high rates of sexual dysfunction even before OCD. That is seen in around 20% cases in one research. Females, around 60% had sexual avoidance, and anorgasmia was seen in around 24% patients. In one research, social anxiety disorder and OCD was compared, and there it is said OCD patients had more difficulty in reaching to the orgasm and less frequent erection disorders and less frequent effective erections. It is explained that OCD patients require to remain in control. That's why there is difficulty in orgasm, because orgasm requires complete abandonment of the self-control. So coming to the neurobiology part, OCD is one type of anxiety disorders. There is huge anxiety associated with OCD. They have enhanced amygdala responsibility, and there is reduced interconnectivity between the areas responsible for emotional processing and regulation, ultimately leading to hyperactivity of the network that mediates the anticipation of the negative outcomes, like anterior cingulate cortex, dorsolateral prefrontal cortex, and on the other hand, there is hyperactivity of the inhibitory systems, that is ventromedial prefrontal cortex. So there is huge anxiety, and there is increased noradrenergic activity over the frontal cortex. Noradrenaline is responsible for the adrenaline rush. See, first time we touch our girlfriend, first time, what happens? There is some current shock like thing. That is due to adrenaline rush, and the chemical responsible is noradrenaline. So this, and during anxiety, increased noradrenaline activity over the frontal cortex reinforce the cortico-striato-thalamo-cortical circuit, which is associated with oriness, and persons getting distracted from the sexual cues and fantasies, and they focus on the intrusive thoughts like getting concerned about the erection. That's why in OCD there is huge sexual problem. And there is also premature ejaculation. What happens in premature ejaculation? It is more related to state anxiety than to trait anxiety, and the result of increased sympathetic supply to the spinal generator of ejaculation. And in delayed or absent ejaculation, what happens with some stimuli, which is stressful stimuli, that is not affecting arousal or not causing increased sympathetic outflow. If it is sympathetic overflow, then it will lead to PME, but that is also not occurring or not affecting arousal. Then what happens? It competes with the sexual stimuli, resulting in impeded sexual enjoyment necessary for proper limbico-hypothalamic and oxytocinergic circuits. That's why there is delayed or absent ejaculation. So etiology part, relationship functioning, then obsessions, that may be relation related, relationship related, or sexual obsessions, and lastly the treatment part. Relationship functioning, OCD patient, they have deficits in social skill, so they are often dissatisfied and avoidant in relationship, less likely to get married, and other reasons are excessive need to control their thoughts and to take control, high disgust sensitivity, and counseling of obsessional beliefs that hamper the person's capacity for intimacy. And for the partner, there is also difficult to understand the patient's thought and behavior, leading to frustration and thinking that the person is crazy and losing respect for them. And OCD and relationships can be explained on three things, that is accommodation, criticism, and effective communication. In accommodation, the partner and the family members participate in the loved one's OCD rituals, ultimately strengthening OCD and affects relationship functioning and diminishes treatment effectiveness. Criticism, it is expressed emotion, again there is poorer treatment outcome. And in communication part, if there is one OCD patient in a family, not only the partner but also whole family is affected, and there is negative associations between symptoms. There is healthy communication is disturbed, and there is negative association existed between symptom severity and romantic functioning, that is intimacy and relationship satisfaction. ROCD, relationship related OCD. Two types. One is relationship center, one is partner center. Relationship center, that is ROCD type 1. Here it is related to the relationship regarding the feeling of the partner, continuous reassessment of the love of the partner or feelings of the partner towards the patient, etc. And in the second thing, focus on the partner's perceived deficit, appearance, stability, morality, intelligence, etc. In both the cases, there will be intrusive thoughts, images, and urges. So these may be associated with related compulsive behaviors. Relationship related OCD, they are distressing because they might be contradictory to what the person is actually experiencing in relationship. So in these cases, repeated checking of one's feeling towards the relationship or partner and perceived shortcomings of the partner will damage the emotional bonds and relationship. Sexual obsession may be related to sex with family members, children, animals, etc. And this thought, action, fusion will lead to behavioral manifestations. And it is believed that in a sexually repressive society, in a sex negative society, individuals with negative beliefs about sex more frequently have sexual obsessions. In 20 to 30% of the individual with OCD report sexual obsessions, and at a given time, around 13% have sexual obsessions. Sexual obsessions tend to more commonly reported in men. Then I will come to the treatment. Sexual dysfunctions associated with treatment. In OCD, we use SSRIs, selective serotonin reuptake inhibitors, and comipramine, one TCA, tricyclic antidepressant, and both these SSRI and TCAs are notorious for their sexual side effects. However, SSRI cause more sexual side effects than TCAs. The sexual side effects due to SSRI have been reported to range from low to around 80% of patients. These increase synaptic levels of serotonin and stimulation of post-synaptic serotonin receptors, resulting in sexual side effects. It affects all the stages of sexual response cycle. And the doses required in the treatment of OCD is quite high than we use for depression. That leads to greater chances of severity of sexual side effects. And we also use other psychotropics that increases the sexual side effects. And in 20 to 40% cases, patients drop out due to this treatment. We have to diagnose according to the history examination part, and two models are proposed, that is please sit and allow for detailed history for that, sexual history and management. And in the management part, management of the OCD and comorbid psychiatric illness is the target symptom. Then we have to work on the psychosexual issues. There is requirement of diet, DHA, and simple interventions like vaginal lubricants and moisturizers are helpful for vaginal dryness. Flibanserin can be used in case of there is hyperactive sexual desire, and medications to enhance vasocongestive response for women with genital arousal disorder, that is also advised. PDE5 inhibitors we use, at times we use daily for improving sexual function. For specific vulvodynia, there is investigation and treatment of underlying conditions. Lubricants can be used. For anorgasmia, penetration and not penetrating vibrating sex aids can be used. Clitoral therapy devices can be advised, and psychosexual support to be given. For decreased libido, psychosexual support, DHA supplement system, etc. can be given. Now take home message, there is huge impact of OCD from sexual difficulty to relationship, difficulty to get married, insecurity, etc. Male, female, both are affected. In females, around 60% have sexual avoidance. In management, OCD and depression, treatment of OCD and depression first, then the psychosexual issues, diet, exercise, improvement of relationship, communication, etc., lubricant, phosphodiesterase inhibitors can be used. Awareness to decrease stigma and taboo are the need of the hour. Thank you.